Good morning. This is Dr. from Oncology. So today I'm talking on dendritic cell cytokine-induced killer cell treatment for solid tumors as well as pancreatic cancers. So the Chen and Mehlman cancer immunity cycle, basically what it shows is that the tumor will release cancer cell antigen, which will attract the attention of antigen-presenting cells. And this priming of the antigen-presenting cells and T cells occur in the lymph nodes. So the mature antigen-presenting cells and T cells will traffic via the bloodstream and then into the tumor, and then attack the tumor cells and release the cancer cell antigen and repeat the cycle. So dendritic cells, which are the antigen-presenting cells, form the core of the cancer immunity cycle by guiding the T cell response. So in terms of immune surveillance, there are two basically systems in our body. The innate system, which basically is for cancer surveillance is the natural killer cells. So the receptor is the natural killer group 2D receptor, which bind to its ligand, MIG A and B, of the inflamed cells or tumor cells and attack them. The other one is the adaptive response, which is the T cells, helper T cells and B cells and the cytotoxic T cells. So that requires a activation by the antigen-presenting cells. So the dendritic cells that mature after they are presented with the antigen, then they would, in the lymph node, they would present this to the T cells. That requires two handshakes. One is the MHC molecule receptor, so that one. The other one is the B71 or B72, which also called CD80 or CD86, that interact with the core stimulator CD28 on the T cell. But the B72, which is CD86, can be an inhibitory effect. So these two handshakes will activate the T cells, but the inhibitory effect of this one, this receptor is CTLA4, is a inhibitory effect on the activation. So that's why if you block the CTLA4 with an antibody, you can improve the activation of the T cells. So dendritic cell activate the CD8 T cells, activate the CD4 T cells, helper T cells, and also the B cells. However, the tumor do not always get killed by our immune system because of something called immune tolerance. So there are a few ways of resisting the immune destruction. The tumor may avoid the fast-induced apoptosis by downregulating the FAST receptor, the cell surface expression, make them invisible to NK cell or CT cytotoxic T cells. They may also secrete FAST ligand and actually, in return, kill off the NK cells and cytotoxic T cells and initiates apoptosis in the immune cells. And the tumor cells can also promote an anti-inflammatory state. Inflammatory state is good for tumor surveillance, the immune surveillance. Anti-inflammatory state suppress the immune surveillance. So the anti-inflammatory state will support tumor growth. And tumor secretes cytokine, which stimulate recruitment of macrophages, and that can turn them into the pro-tumor macrophages called the M2 macrophages, which is also a kind of immune suppressive effect. So dendritic cells are phagocytes that process and present specific tumor antigen to T cells. So the inactive dendritic cells need to mature into the mature dendritic cells, which are antigen loaded, with new antigen for them to be functional. So dendritic cells act as antigen-presenting cells that activate T cells to attack. Without dendritic cells, the T cells cannot perform their functions because they cannot recognize antigens. So the mature dendritic cells can aid in the clonally expanding specific tumor-directed CD8 and CD4 T cells. So if you want to use dendritic cell as a vaccine, so what it does is that it is a antigen-presenting cells, so it captures the tumor-associated antigen, which you can present it to the immature dendritic cells, for example, in the form of tumor lysate. So you give tumor lysate to it, or the mRNA vaccine. So mRNA vaccine with the tumor-associated antigen, so that can activate the antigen-presenting cells, or the toll-like receptor ligands, which are pro-inflammatory, Also, there are other ways to activate the dendritic cells like viral vector or CRISPR technology or RNA sequences. So after you have matured the dendritic cell, then they are ready to activate the immune response. So dendritic cell also act direct killing on tumor cells, release and uptake tumor antigen. And there's one example of successful dendritic cell therapeutic vaccine, which is Provenge, the one licensed for treatment of refractory prostate cancer 14 years ago. Cytokine-induced killer cells are a mixed match of peripheral blood mononuclear cells. They are engineered by antibody cytokine cocktail and expanded ex vivo for approximately 14 days. So it is a heterogeneous group of cells. Their characteristics are CD3, which is a T cell receptor, and CD56, which is the NK cell receptor. So they have mixture of CD3, CD8, and CD3, CD56, if you want like NK cell, and it could be CD3, CD56 negative. So the function of the cytokine-induced killer cell determined by the ability to function independently of the MHC complex, because it has the natural killer group activity. Because the MHC complex restrict the target for the immune cell, for T cells, for example. So the cytokine-induced killer cells, by having a more indiscriminate receptor with the NK natural killer G2D receptor, so it is not restricted by the MHC. So this is the MHC restricted with the T cell receptor interacting with MHC type 1, so on the target cell. So that's the T cell MHC restricted killing, and this is the natural killer cell-like killing, which is the NKG2D, so CD56, interacting with the receptor targets. The targets for the NKG2D receptor are mainly MHC class 1 related molecules, which is called MYC A and B. Also, the unique long binding protein, ULBP. So the receptor is an activating receptor. So it detects and eliminates tumor cells by interaction with the ligands. And these ligands are exclusively upregulated on the surface of malignant cells. So you don't get so much of these ligands in the normal cells, and result in granule exocytosis and secretion of cytokines and interferon alpha gamma. So the cytokine-induced killer cells kill both the tumor cells, mediated by fast ligand and perforin, which is the main way to kill tumor cells. The NK-like structures, such as DNAM1, can also be involved in the recognition and killing of tumor targets. However, we saw that just now, it also has the MHC restricted receptor. So the MHC restricted manner by T cell receptor engagement can also be another way to kill the tumor cell. So it has both the specific and less specific engagement of the tumor cells. This is called the dual functional capability. So the dendritic cell based immunotherapy is specific active immunotherapy, because it's a kind of vaccine kind of thing. So dendritic cell based immunotherapy, you can target a certain type of cells by how you mature the dendritic cells. And the cytokine-induced adaptive immunotherapy is a kind of passive immunotherapy, but because of its heterogeneous cell population, 58% are T cells, 38% are NK cells, and 3% NK T cells, and 3% are NK cells, they can counter the issue of mutation and downregulation of antigen in tumor microenvironment. So when we look at the cytokine-induced killer cells, the population, so they are more CD, so compared to the peripheral blood mononuclear cells, they have more CD3 expression, they have more CD4 expression or CD8 expression. So the cell, the receptors are over here, and then and more CD56 expression. So this is a study of NPC patients. So they give a higher concentration of the CIK cells and get more cell lysis and use it in patients. So these are patients on control group. So standard treatment is a patients with control group plus infusion of the cytokine-induced killer cells, and demonstrated better DFS and OS in this cohort of patients. So the cytokine-induced killer cell and case is used in liver cancer. So you can partner it with a few other tumor lysing technique. So if you use TACE, so this is a illustration of what we said just now, the NKG2D interact with the ligand like MYC A, B, or B, and there's a CD3 receptor and interferon gamma release, and then release of the perforin and granzymes that kill the tumor cells. So this is essentially the process and cause the tumor lysis. So in this series, they noted if you have TACE alone, the PFS 1 year is 7.7%, 2 year 2.6%, went up to 40% with the addition of the cytokine-induced killer cells. And also they show an improvement in OS for the liver cancer patients. So combination of this combination with RFA, so before you do the maturation, you have to take the blood from patient. So you do apheresis, and then you get the cells, and then you process it, and you do RFA. That's 1 week before, and then RFA, and then you can infuse it back when the cells are mature, and then you can repeat the same process. So it is infuse back NK cells, gamma delta T cells, cytokine-induced killer cells. So in this study, they show that RFA combined together with the cytokine-induced killer cells had significantly higher PFS than RFA alone group. So there are quite a few studies already. So these are for liver cancer. So with different combination, resection versus resection plus immunotherapy, infusion of a few of the cytokines, reported better relapse-free survival, combination with TACE, also improved PFS and OS, TACE RFA, significantly longer DFS and DFS in a CIK group, and also partnering with TACE and RFA. So in lung cancer, this is just a timeline of the Chinese lung cancer immunotherapy timeline. In Western, it's similar, which is the pembrolizumab, nivolumab that we use. But in China, they have the sintilimab as well for lung cancer. So in lung cancers, these are a couple of papers, one by Li et al. So they have early stage lung cancer patients use the chemotherapy. There are 3 different combinations, cisplatin, paclitaxel, or gemcitabine, with or without the CIK infusion. And also advanced cancer patients that had 4 cycles of the chemotherapy with or without the CIK infusion. What they reported is for early stage patients, the 3-year OS or overall survival went up from 66 to 82%. For the advanced patients, the 3-year OS went up from 3 to 31%. So there is data to suggest that CIK cell immunotherapy could improve the efficacy of conventional chemo in non-small cell lung cancer patients, and increased frequency of CIK cell treatment could further enhance the beneficial effect. Later on, they did a randomized study, which is actually another randomized study on the same group. So with the CIK chemotherapy, there's a waterfall plot, more responses and more stable disease compared to chemotherapy. This is the survival of the PFS and OS with or without the cytokine-induced killer cells with a hazard ratio of 0.22. So if you put this in a kind of antibody study, then it will be a blockbuster because the hazard ratio is so remarkable. The Kaplan-Meier curve separates so much, but this is cell therapy, so the threshold of starting this service is actually a little bit higher, so it is a bit more difficult to catch up. But it is there are data that show that it is a very clever way of doing it. What about partnering with the checkpoint inhibitor that we use frequently? So these are the these are the immune suppressor cells, myeloid-derived suppressor cells, T regulatory cells. They produce IL-10, TGF beta, nitric oxide, those kind of things, arginine to inhibit the T cell. The dendritic cell via the MHC restriction and the co-stimulator CD80, CD38 interaction will activate the T cells. So this inhibition is activation, but it can be inhibited by the tumor cells via the PD-L1, PD-1 interaction that we know well about, and also CTLA-4, CD80 interaction, B7-1, B7-2. So if you inhibit these checkpoints, then you can activate the T cells again. So that is the idea of the current antibody immunotherapy checkpoint inhibitor. So if you add that into the immunotherapy into the regime for advanced lung cancer, so Dr. Lee reported 2 years ago that advanced lung cancer received sintilimab and the chemotherapy tablet and then had the cytokine induced killer cells 3 weekly for 4 cycles, and then maintain with sintilimab for squamous and sintilimab and pemetrexed for non-squamous until disease progression. So it is a single arm study, but very remarkable result. Look at the spider plot. So a lot of patients actually respond and stay responding and after many months. So this, although it's a single arm study, you don't see this kind of spider plot when you treat advanced lung cancer patients. And the waterfall plot and the swimmers plot, all very impressive. So I think this shows that there is a signal that giving the cytokine-induced killer cells with the checkpoint inhibitor may have even better outcome compared to what we normally do, just give chemo plus the checkpoint inhibitor. So these are the systematic review of the studies that have been done, and basically it show adding the cytokine-induced killer cell improve OS from 45 to 56%. Immunotherapy combined with chemo shows significant improvement in disease control rate, also better overall response and disease control rate, and maybe better OS in 3 years. What about colon cancer, which is traditionally not a very immune-sensitive, immune-responsive tumor? So there is a small study on colon cancer. So 46 patients just give FOLFOX with or without the cytokine-induced killer cells after the FOLFOX, after the day 6. So give the CIK cells. So in the first 2 years, they found that in the cytokine-induced killer cell group, the recurrence rate was 26% versus control group was 43%. Also, survival time was also longer in the CIK group, 41.9 months, versus control group, 33.8 months. So that means the cell therapy may also work for those traditionally cold tumor. Colon cancer, most of them are cold tumor. They are either immune desert or immune excluded. But by using the cell therapy technique, that may be one way to improve the outcome. So just to go through the technique of doing it, so you have the peripheral blood mononuclear cells, which is isolated from the patient. So you get the monocytes, and then you make into cytokine-induced killer cells, and then have to do quality tests, and then infuse it in daycare. That's what it is. So there's blood transfer, the Barbicort, centrifuge, discard the plasma. This is a lab thing, H3 coach, I don't know what it is, but Kenny's lab will do this. So now we have this lab in UMMC already, so we can do more studies, and we can probably even use this in clinical practice. You have to purify the monocytes, add culture medium, and culture box incubate, and incubate against the antigens and quality tests on the CIK cells. So we look at the quality test and monitor the CIK cells for viability, and then that's the bag that we get and infuse back to the patients. So this is actually the trick here, which is how you mature the dendritic cells and the cytokine-induced killer cells. Dendritic cells apparently only take 3 days to mature. So so it is a very fast process. So you can mature against different antigen. And then the quality control process is you have to check for germ-free for aerobic and anaerobic germs, mycoplasma, endotoxin, and you have to retain it. So the cytokine-induced killer cells, when you do the quality control, it has a lot of CD3, as we saw earlier, CD3, CD8 receptors, and CD3, CD56 receptors. So you need to have those kind of cell population for it to be meaningful. So CD73, 90, CD105. So the guideline from Taiwan and Japan says that minimum viability should be 70%. You should use a cryopreservation process validated to preserve potency and maintain at least 70% viability. So in Penny's lab, survival rate is 90 to 94%. Culture of dendritic cell. So this is just we said just now, 3 days for differentiation, and then another 2 days, 5 days for duration, and then another 2 days for maturation. So these are dendritic cell. So these are the testing of the quality of the T cells. So it needs to produce the interferon gamma for us to know that it has the activity. There are functional T cells. More than 90% of culture cells belong to cytotoxic T cells achieved. So what about cytokine release storm and this kind of thing? So actually with this technique, because cells come from a patient's own body, and the adverse reaction, before we started our study, I was quite nervous. We get anesthetist to stand by in case patient had the cytokine release storm and had the pulmonary edema and got admitted to ICU. But so far, it has not happened. So adverse reaction related to treatment included fever, chills, fatigue, nausea, and vomiting. CIK cell therapy is safe and well tolerated. These are the toxicities that can happen: fever, anaphylaxis, cytokine release storm. Just to talk about our protocol, so this has been running for a year plus now. So this is the dendritic cells and cytokine-induced killer cell for pancreatic cancer, which is the most deadly cancer. So we wanted to recruit 54 subjects with relapsed or refractory stage 4 advanced pancreatic cancer. So take the cells from the patient and then get the dendritic cells, mature dendritic cells, and then the cytokine-induced killer cells. And then they have to be combined together for the dendritic cells to activate the cytokine-induced killer cells, but not for long, and it infuse back. Okay? So that's the process. And actually, we can take the tumor tissue and use it to mature the dendritic cell, or just use a library of pancreatic cells antigen. That's basically the process. So patient had their standard chemotherapy for Fadhlina or gemcitabine-based chemo, and then they have stable disease, at least 3 months life expectancy. Then they get randomized into TS1 alone or TS1 plus dendritic cell, cytokine-induced killer cell, and then they have the cells infused back to them. Day 1, day 15, 3 weeks out of each month. So this is the first patient, that's the second patient. So now I was just told we have screened 17 patients, and now 6 patients are on active treatment. So what we thought is that the benefit of combining dendritic cell and cytokine-induced killer cell are you can able to embrace heterogeneity nature of the pancreatic cancer. You can boost the patient weakened immune cells by extracting their own immune cells and then clonally expand ex vivo and reinfuse back to them. And then reducing immune boosting time through diet alone or diet and exercise. So it can actually help to boost the immune response. Personalized through incubation of patients on serum cells and biopsy sample tissue. And it does not have a lot of toxicity. Thank you.
Thank you very much, Prof. Ho, for that very exciting talk, taking us through the future in oncology. Just listening to that talk, I was just wondering if your thoughts on how many cycles of treatment the patients should go through, because in your pancreatic cancer trial, I saw at least 2 cycles of treatment. So do we see durability of this response?
So currently we still have a couple of patients who are still in kind of remission, although they are also on TS1. So we need to give at least 2 months of it, but many patients actually get 3 months and some get the 4th month. But we probably don't exceed the 4th month of infusion.
And afterwards, in terms of looking at other tumor subsites, so do they usually do up to 4 cycles, and is there a durability of response that they see?
Yeah, so because I think it's because of the antigen presenting cells, the dendritic cells, which basically act as a vaccine. The cytokine-induced killer cell, you need repeated infusion if you want it to work. So that one is a passive immunotherapy. But the active component can receive from people's report, can generate quite durable long-term response, a bit similar to what we see with some patients with checkpoint inhibitor. So yeah, so I think it's a kind of a bit like the Provenge story for prostate cancer. So you just vaccinate the patient against the tumor.
Fantastic. And I see that clearly there are a variety of ways that we can combine this treatment with local regional therapy in HCC. And we see combining with immune checkpoint inhibitor in lung cancer. What do you think is the most exciting partner for cytokine-induced killer cell therapy?
I think, first of all, of course, we would probably try to use it for those which are more inflamed tumor, lung cancer, liver cancer. But that's why the colon cancer study is quite intriguing. For cold tumor, you may also able to get a better response. Actually, I think this story is real, because Dr. Tunku Kamaru dragged me to talk to a Taiwan group that do the gamma delta T cells. And his collaborator in Nosero, the scientist in Taiwan, disappeared from the scene for 2 years and then reappeared. Turned out he had advanced colon cancer, and then went for Fox chemotherapy, followed by gamma delta T cells. And then he came to KL. We met him totally fit and well, just on maintenance UFT folinic acid. So I think gamma delta T cells, basically this kind of, but he needs to have the gamma delta T cells infusion continuously because it's a passive immunotherapy. So that means there are colon cancer patients, supposedly MSS, the microsatellite stable type, that can still be induced to respond to immunotherapy.
Wow, that's a great story that you've shared with us. In terms of the manufacturing time, just thinking about from collection of the peripheral blood to infusing back, how long does that process take?
So far in our study for past 1.5 years, the delayed manufacturing occurred 2 times. So I think usually it takes about 4 weeks or so. 4 weeks we expect to get the cells ready. Yeah.
Okay, so I just would like to invite the rest of the audience to participate, and you can chat or type in your questions in the Q&A if you have any questions to ask here. I also wondered in terms of your thoughts about combining it with radiotherapy. Clearly, one of the endemic cancer that we have in this region is nasopharyngeal carcinoma, and it's we do need a lot more work in that because it's endemic to our region. So what are your thoughts about combining CIK with radiotherapy?
Yes, definitely. So there was that paper that earlier that they showed giving it with CIK cells for NPC had better effect, better outcome, better survival. I think it's certainly a project that we can design. It to buy the dendritic cells, cytokine induced killer cells, such as any cell therapy in market value is actually quite expensive. It costs about, I think, Penny can correct me if I'm wrong, about 200,000. If you can get, because OxyLab is in our university, in our hospital, so if we can persuade her to give us a bit more sample and run a protocol and NPC, I think yeah, we can negotiate. Penny. I don't want to take advantage of her, but it is something that we can consider.
Great. That's really awesome to hear. So hopefully there will be more studies coming up in this scene using the collaboration that we have. Thank you very much, Prof. Ho, for the exciting talk. And I will turn to our next speaker and moderator. Thank you so much.
Thank you.